I'm sorry for my English that is not improving. Anyway, um, I would be very happy to be with you. I'm very sorry not to be there, but I really wanted to participate all the same. I'm going to speak about what are the problems dealing with Jacobsen syndrome. Um, First, I don't know how many of you are new with Jacobsen syndrome. I know that some know very much, maybe more than myself, about Jacobsen syndrome. Jacobsen syndrome is a syndrome characterized by some facial dysmorphics, some disability, organ malformation, and is due to a chromosome deletion, loss of a piece of chromosome. This is my first patient. She had a very wide deletion, and she also was very dysmorphic. And these are my other first patients. This is Giuseppe Bucolo, some of you know about, and this is only came because of short stature. He had very little and the smallest deletion. The incidence is 1/100,000. There are few cases reported in the literature, and we know quite well what the main features are. Apart from facial dysmorphism, physical growth problem, disability, the most important aspects are lack or reduced platelet number and function, immunological problems, heart abnormalities, malformations, and there may be problems with any organ. The widest deletions that were diagnosed in the olden days, they were the only ones that were seen because under the microscope you need to have a wide deletion to see, may get rid of 246 genes in the widest deletions. But not all these genes give straight away something abnormal, because each of us has two chromosomes. One is normal and one is deleted, and the normal one compensates in part for the deleted one. To be able to manage a patient with Jacobsen syndrome, we need to have full genetic diagnosis and full clinical diagnosis. This is not always possible. Sometimes we must navigate on site because we don't get full genetic diagnosis or full clinical diagnosis. Genetic diagnosis in the old patient was performed via standard karyotype, maybe with the chromosome fish painting. You can see here how chromosomes are very well seen when you paint them. But nowadays we have CGH array that is a kind of measure. The amount of DNA of the patient is compared to the DNA in normal DNA, and the amount is taken into account. So we know with the CGH array if there is any loss or gain in DNA. If there is any abnormal amount on chromosome 11, and we know exactly which part, so we know which genes are missing, if there is any additional imbalance, but also we may have some problems because we may find variants of unknown significance. It means they are called WOOS, variant of unknown significance. They are loss or gains that may not be associated with a clinical problem, and they leave incomplete diagnosis, may leave an incomplete diagnosis. We also can see if it is a terminal deletion or interstitial in between, in the inner part of the chromosome. And there is another kind of array, it's called SNP array, that gives additional information: the parental origin of the abnormality, and also if there are homozygous regions, which may cause some additional features. If we see here, this is the drawing of a chromosome 11, and these are, each of these line is a patient with a deletion, wide deletion in these patients, smaller deletion in this. And you can see the blue area, this blue area indicates this, the patient with the smallest deletion who still has Jacobsen syndrome. And this patient that has Jacobsen syndrome has an interstitial deletion within the Jacobsen syndrome region. So the Jacobsen syndrome is missing, but the telomere, the bottom of chromosome 11, is still there. This is the Jacobsen syndrome region. Next generation sequencing is another way to add information. We may sequence a gene, sequence many genes, or sequence the whole exome, means genes that are translated, that produce a protein. Or we may sequence the whole genome. But the wider we go, the more we get confused with a number of variants. So we must do it under the request of a geneticist with a special defined request of information. So for a complete diagnosis, we need to have traditional karyotype and FISH, array CGH, or SNP array. Maybe we might want some next generation sequencing, but to select the best procedure, we need to have full clinical information and a genetic counseling to drive the tests. Remember that nowadays we start with arrays, and sometimes the karyotype is not performed, but I must tell you that performing karyotype gives additional information, even if array has been performed. Remember, in fact, that any test alone can give incomplete or even wrong results. Karyotype may miss or misdiagnose the abnormality. Array is bound to miss all balanced abnormalities and may find whose we cannot give any meaning. Any test may be missing mosaicism. This means that any test you perform on its own, you cannot see that the patient has two kinds of cells, normal and abnormal one, or two kinds of different abnormal ones. I have few patients with the lesion 11q who also have duplication 11q in a mosaic form, and in some patients only one cell line was spotted on CGH array, and the two cell lines were seen by karyotype. So the test should be completed. And any result needs updating. If there is a new technique, the new technique should be taken into account and see if it gives more information. The family history of Jacobsen syndrome is usually negative. The Jacobsen syndrome is usually a single case. There are rare cases of recurrence. But anyway, if a family has had Jacobsen syndrome, prenatal diagnosis should be offered. Family history, generally, patients have normal chromosomes, but one parent may also be affected with Jacobsen. We have a few cases with a mother with Jacobsen syndrome. A parent may be a mosaic and then may be not so much affected, having a mild phenotype. There may be familiar balance translocation. These three instances are at high risk of recurrence. Parents may have a fragile site, and there are few reports of rescue of monosomy. What does it mean? Two cases reported in the literature. The mother, uh, after the test was performed, resulted to be a Jacobsen syndrome as an embryo, but the chromosome that had lost a piece of chromosome of 11q was restored in the prenatal period, and the mother was normal, but it was clear that one chromosome 11 was um, was produced by copying the normal chromosome by the abnormal, the deleted chromosome. So the deleted chromosome was healed in the embryo. Family history is usually negative. However, both parents should have chromosome tests, including FISH, to see if there is a balanced translocation, and maybe search for mosaicism. Parents would have usually normal CGH array because they are not unbalanced, and CGH array only can see abnormal amount of DNA. But if one parent is affected, it should have CGH array. And in the case of a child with a WUS, we don't know what kind of, if the deletion is connected with the phenotype of the child. We must check if the WUS is present in the parents, in one parent, and if the parent is also affected or not. This is my first patient who had a fragile site. The fragile site gives a chromosome that is broken and loses bits, so that before the chromosome is healed, because it must be healed to divide in the next cell, before it is healed, loses bits. So the breakpoint is not at the point of the fragile site, but higher up, and maybe in different sites of the chromosome. So ideally, affected person should have a traditional karyotype and FISH and array CGH or SNP array, and parents, traditional karyotype and FISH, sometimes array, search for mosaicism. Fragile site should be searched on research ground only, because I have seen many reports in the literature that they say there was no fragile site, but the fragile site was not studied with the right techniques. Clinical diagnosis. We must check for developmental delay, disability, physical growth, dysmorphic feature, organ malformation, abnormal organ functions, and remember evolutionary aspects. things that may change with time. This is expression. Expression can be mild or severe. And here you can see many faces with the mild or severe dysmorphic feature. The expression is variable. It depends on the size of deletion and the genes involved, how many genes are missing and which genes are missing. If there is a mosaic and non-mosaic condition, if there is additional imbalance, and also genetic compound. We don't have only chromosomes 11, we have 23 couple of chromosomes. So the other genetic compounds are important, and environment, epigenetics also contribute to the phenotype. So phenotype can be different in patients with the same deletion. Human chromosomes and genes interact. We know that one chromosome 11 is broken, but we know that there is the other one. And remember that genes are like the instrument in an orchestra. So we may be missing one violin, there is no problem. We may be missing the piano, and the orchestra cannot sing, cannot play the right music. If there is a drum missing or a drum in addition, is a big problem. So within the number of genes that may be missing in Jacobsen syndrome, some are irrelevant and some may be very important. Furthermore, chromosome 11 interacts with the other chromosomes, and the genes that are missing in chromosome 11 would interact with genes in the other chromosome. So you can have the same deletion in two patients, while one has some something compensating, another one may have something making it worse. So there may be difference in the aspects, in the clinical aspects. During pregnancy, the pregnancy may be a term in 2/3 of cases and normal in the 2/3 of cases. But in more than 1/3, there may be problems, mainly in intrauterine growth retardation, but all problems with the placenta, polyamnios, high blood pressure in the mother, threatened abortion. Clinical diagnosis during the prenatal period, using the prenatal, all the prenatal tests, maybe you don't find the abnormality. Test is normal. Ultrasound scan can be normal in 2/3 of cases. Even amniocentesis has given normal results in 60% of cases. Because, as I told you, the chromosome analysis is something you do under the microscope, and the chromosomes are short, difficult to look at. But nowadays, there are two ways how the prenatal diagnosis is picked. Is sometimes prenatal screening, NIPT, can find the abnormality, depends on how deep is the analysis, and CGH array, of course, would not miss. But sometimes you might find a deletion and not know if it's dangerous or not. At birth, you have a small baby with dysmorphic face, but the most important problems are heart malformation, bleeding, pyloric stenosis, feeding problems. Sometimes you would need tube feeding, and pulmonary problems. Clinical assessment would need a lot of specialists, pediatrician, neurologist, cardiologist, hematologist, immunologist, endocrinologist, ophthalmologist, audiologist. and a number of equipment, scan. If you, in the early period, in the perinatal period, you can scan brain, and you should scan heart and abdomen to see kidneys. RMI should be done on the brain, EEG, X-rays, and blood test, routine blood test, but also number and function of platelets, immune system, endocrine system, kidney function, and liver function. In the follow-up, clinical information must be updated and genetic information must be updated. If we have chromosome traditional studies, you go to the next. If you have array CGH, you go to chromosomes. This is the children I have seen. The number is almost 80% are pure deleted. Clinical aspect, there is a developmental delay, intellectual disability, I have told already, and assessment of developmental delay, intellectual disability, and when the child is about 3, autism-specific tests should be done. Basic assessment should have a follow-up. EEG, brain scan, MRI, X-rays should be done according to the phenotype we have spotted at first. MRI shows white matter problems. In the differential diagnosis includes inborn error of metabolism and even problems that are more severe than Jacobsen syndrome. Hypoplastic sella turcica and small pituitary gland, hypoplastic corpus callosum, bleeding, and bones anomaly, among which cervical spine abnormality. There is a disproportional growth. The children are usually short, the head is relatively large. Some patients have trigonocephaly due to premature closure of some of the fontanelle of the skull. You see how many children are short, less children have a normal height, and few children are tall. If the stature is short, but also if children are very tall, growth curve is important, and hormonal test is to be performed, GH and TSH. Head circumference is usually normal, but because children are short, the head looks large, it's relatively large. Sometimes it's really large, very large. Sometimes it's small. So MRI should be done and with follow-up. But is it wise to operate on trigonocephaly? This depends on if the brain is growing and developing normally. Although the head has an abnormal shape, the brain may be growing normally. But if it's not, it would be necessary craniotomy to let the space for the head growing. If the brain is growing and developing normally, the surgery, so the operation may be aesthetic only. About 90% of children have surgeries. Many children have more than one surgery. Heart, skull, pyloric stenosis are the most relevant, important ones, but also eyes and ears, ptosis, strabismus, tear ducts, and ear tubes. Remember, ptosis and strabismus may be considered minor surgeries, but in fact, if a child with ptosis or strabismus may lose the sight of one eye, may be losing one eye function, so must be treated. There may be complications during surgeries. 25%, it means 1 on 4. There may be bleeding, but we can prevent from having handy platelets or full blood during surgery. Anesthesia, because there have been problems with anesthesia because the throat is narrow. So this is something the surgeon, the anesthesiologist should be aware of. There have been few cases of cardiac or respiratory arrest and pneumonia. Usually there are good results, not always. Of the more severe is the abnormality to be corrected, the, the less the chance to have good result. With eye surgery, there are often relapse of strabismus and ptosis. The heart is a real problem. Pediatric cardiologists must perform basic assessment and follow-up, and possible remember that may be evolutionary problems. Scan, repeated scan in the ears, EKG, and children may be treated with medications or surgical treatment according to the cardiologist's opinion. Dysmorphic feature. We used 122 items to describe faces. The faces help in the diagnosis, may have just aesthetic relevance. Usually our children are very nice, but may have functional relevance. Ptosis, I told you, may make difficult for children to walk, or there is a variability of expression that we can see. In this table, I have all the list of eyes abnormality, and you can see that all patients that have something, I have a red spot. So this area is not, there is nothing wrong with cataract, lens dislocation, retina anomaly, very few. But almost all children have ptosis, downslant, palpebral fissures, hypertelorism, epicantic folds. And these are what is seen. If we see nose, the nose are very varied. Children may have all different kind of dysmorphic nose, but they don't have a big nose. Usually they don't have, only 2 big nose, deep philtrum only 4. So the nose is more variable. I'm not going through this. So you can see that there are children that have the same features, but various degree of severity. Mild, more severe. And the children may have all different kind of faces. And this is a reconstruction of 3D shape made by Peter Hammond. The computer may tell you if the child falls within the 11Q face or not. Hands are very typical. You see the narrow, this region is narrow, and this is very unusual. But within the same kind is a more severe aspect than this. Feet are also quite typical with this big first toe. And the other abnormality we see is, the most frequent is low platelets, recurrent infections, heart malformations, and skin anomaly. Remember that these numbers refer to children that have after the neonatal period, because I have only seen patients in outpatient in office. There are also skin problems, eczema, viral infections, unusual scars with exceeding scar or thin scar. But we did 2 skin biopsies, but without finding any abnormal growth of the connective tissue. Vascular problems are serious problems. There may be breakage or narrowing of blood vessels. So the potentially serious conditions are bleeding, especially if the brain or intestinal region is involved, and pulmonary infections and skin infection are not so severe. Skin infection are usually not so severe. There are some unanswered questions. Is life expectancy, but we now have a whole lot of adults. And very recently, I have seen a patient in his 60s. He is the uncle of a young patient of mine. We made the diagnosis after the child. So there may be adults that don't even know they have Jacobsen syndrome. We don't know if there is a cancer risk. There are very few reports, a couple, and we don't know the cause of death, but mostly are hemorrhage and severe infection, untreatable infections. This is the landscape from my window. I want to share with you. I have finished my presentation. It has been shorter than okay.
We're not seeing your video. Do you want to share that?
We don't see your video.
Yes, I see. Can you see me now? No.
No.
I don't know what happened.
That's okay. We'll ask a few questions if you have some time.
Yes, of course. I made it short because I didn't know how long it would take with my English.
You did great.
Dr. Mattina, this is Bonnie Sim. I don't know if you can see.
Sorry, I can't hear you.
Yeah, we don't.
Maybe we need to come here and come up through the computer, so she can see it.
You won't need that.
Okay. So, can you hear me now?
Yes.
Okay. So, Dr. Mattina, this is Bonnie Sim. I think we've had some email correspondence in the last couple of years about Megan. She's 30, she'll be 34 next month, and has had some progressive white matter disease. She had earlier when she was small, they saw some on MRI, and then it seemed to be static and not be a problem. But now in the last couple of MRIs, she's had marked progression. And I think when we met with Dr. Grossfeld the other day, he said that we kind of want to get an idea in the future as people are aging, what kinds of things that we might be looking at. And I'm hopeful that maybe you'll help us to understand this white matter disease and progression, and if it's.
I cannot put the video on anyway. Can you hear me?
Yes.
Yes.
Yeah, we can.
I think there are at least 2 things you could do. One is please send me the MRI, a copy. I want you to keep your MRI, but I would like to look at it because I have many, and I would like to see what's wrong. And second thing I would do is NGS. This is the time you may want to analyze genes connected with white matter.
Oh, okay, okay, good.
If you want, we can do it for you.
We haven't even had the array done. We've just had the karyotype. So that's how far behind we are.
Don't even you don't have array.
Don't have, no, we don't.
You should have arrays.
Yeah.
I cannot open. I'm sorry. Bonnie Sims, is it?
Bonnie Sim, I can email you.
Yes, please. I will find your files, what I have got, and
Okay.
you update me, and I update you.
That sounds good.
And this is one of the conditions where NGS can be useful, because
Good.
there are a number of genes that we may want to analyze on the left chromosome 11, the one that is not broken.
Okay, great. That's good.
That
That's
one,
good.
there may be some variant that is making it worse.
Right. Okay. Thank you. I appreciate you taking your time with that.
It's my job.